Hello, I'm Tom Stevens. Welcome to the Tombot Fireside Chat series. Fireside Chats are interviews with experts from the fields of health, technology, and pets, along with stories shared by the family members of those suffering from health adversities. My guest today is Dr. Matthew Lefferman. Welcome, Dr. Lefferman.
Hi, Tom. Thanks for having me.
Dr. Matthew Lefferman is founder and chief medical officer of Access Healthcare Associates. He completed portions of his internal medicine training at Hahnemann University in Philadelphia, Pennsylvania, and Banner Good Samaritan Hospital in Phoenix, Arizona. Since that time, his professional focus has been on the field of geriatrics. He has several years' experience as a physician working in the home setting and in skilled nursing facilities. Additionally, he serves as medical director for a hospice agency and for a medical wound care practice. Dr. Lefferman was my mother Nancy's physician for the final years of her battle with Alzheimer's. Dr. Lefferman, how did you become interested in the field of geriatrics?
So the nice thing about medicine is that it's not just one box. There are many different options based on your personality, based on the work schedule that you like to keep. And I always had a very positive relationship with my grandparents. As I met my wife and spent time with her family, had a very positive relationship with her grandparents, and really connected to the older generation. And as I was finishing my internal medicine residency and looking at different practice options, I saw that there was really an unmet need as far as quality medical care being provided to the senior population, and it excited me to help them. It's not always glamorous medicine, but it brings in a lot of different disciplines as far as medicine, psychology, social work, to really help the patient.
The changing needs for a geriatric patient as they move from maybe a relationship with a primary care physician that they had through their earlier years to one that they might have with a geriatrician. How do their needs change, and how does the expertise from a geriatrician's point of view really, how is that different from what they might expect from their primary care physician?
So there definitely is a spectrum as one ages, and there are not hard and fast rules, because obviously you could have a 70-year-old who's quite debilitated physically or cognitively, and we have 100-year-olds in our practice who are quite active physically and cognitively. In general, my niche is patients who are on towards the end of the spectrum, needing a lot of help physically, cognitively, with dementia, malnutrition, falls, difficulty getting out of bed. And so that's really clear that they could benefit from someone who's focused on those particular issues. But I would say in general, as one transitions from a healthy 60-year-old to potentially needing a geriatrician, it really depends on when issues such as memory loss start becoming a problem, lack of mobility, lack of nutrition, maybe depression related to later in life, and so that's when these start becoming an issue. It really helps to have someone who has an eye focused on those issues, more so than just the whole body, which is really important, but how the whole body affects a senior.
The slogan for Access Healthcare Associates is modern house calls. House calls are reminiscent of a bygone era. How did you determine that mobile geriatric care would work so well in today's world?
So my first job out of residency was working for a medical group that wanted to start a program helping seniors at home. Actually, I should backtrack, helping any high-risk patients at home. And so it really opened my eyes to the need for focused care in the home. And as time went on and as I did more research, I saw how big that need was. And the particular niche that I really then, when I started my own practice, wanted to meet is residents of assisted living communities. I do see patients at home, I do go to nursing homes, but in particular, this is a cohort that they're certainly paying a lot to be in a facility, and these facilities meet certain needs, mostly social needs, but their medical needs frequently go unmet, and it's the facility's role to take on some of that challenge, and so they need a partner, and that's really where I step in. And as far as the slogan "Modern House Calls," it's bringing in different disciplines. It's bringing in technology as it can help to benefit the patient, help to benefit me in seeing patients and being more efficient.
When you started treating my mom, one of the challenges that we had was the lack of her mobility, the lack of just the difficulty in getting her bundled up and into the car and transported to her doctor's offices. Do you find that mobility is a strong reason for people to use a service like yours in the home care setting or in the assisted living facility?
For sure. Falls, weakness, strokes, they're common conditions in the elderly, and it's the other aspect is that these facilities are taking on the task of transporting a resident to the doctor. Sometimes the family's involved. You were quite involved, but that's not always the case. So the facility has to step up, and it's very challenging for them. And it's potentially sending another staff member with the patient to the doctor, because it's frequently the melding, like I said, of physical and mental, and so there could be cognitive issues that affect their ability to go out to the doctor, in addition to the physical issues. But very much to get to the core of your question, my focus is mobility, because age-old adage, if you don't use it, you lose it. And from my perspective, any movement is positive. And even if someone can't get out of bed, there's movement they can be doing in bed that's beneficial.
Seeing patients in an assisted living facility also makes a lot of sense in terms of managing your resources, having a concentration of patients within a single location. We read about the challenges posed by the Silver Tsunami as the baby boomer generation reaches retirement age. Has the tremendous growth in numbers of seniors required you to modify or scale your practice to meet increased demand? It
would be interesting to see how it would answer that question 2 years ago prior to COVID, and how it answered that question now. The news headlines that you hear about difficulty in finding staff, keeping staff, is particularly acute for us, and I think in healthcare it's very challenging. A lot of people have burned out. I mean, we had COVID took a significant toll on our patients, certain staff members, it took a toll. So as far as having the team in place to continue to provide a high level of care and quality care, it's quite challenging. And we've had to pivot, and we utilize more and more remote employees. We have a team of virtual nurses who are in the Philippines, and so they're not making treatment decisions, but they're helping with a lot of the busy work as far as scheduling, sending in prescriptions, faxes, etc. So that's one way that we've really had to pivot. And I would say, COVID has really shaken up the need for focus on clinical care for seniors in general, and families are more and more involved in their seniors' health, and they're more and more wanting direct input from us, because maybe they haven't been in a building for several months. Like, hey, what's going on with mom? Can you tell us? So the communication piece has grown and grown, and the need to communicate, and we're as much a communication hub as we are a physician, medical treatment hub.
So speaking of COVID, we're bracing for potentially another surge with the Omicron variant. Has the pandemic affected your ability to deliver the geriatric care services? And for example, have you begun using technologies such as telehealth to try to extend your capabilities?
So, one of the positive things that the federal government did when COVID started was they allowed for physicians to utilize telemedicine for Medicare patients. Previously, it was only in rural areas. So now every patient can have a visit from a doctor through telemedicine. I would say there were about 3 months where I was not going into senior facilities because it didn't make sense to go from one building to the other. They didn't necessarily want me in there. I didn't necessarily want to be exposed to COVID to such an extent. So yes, we did have to pivot and utilize telemedicine pretty much for all our visits. And I would say now the challenge is kind of getting back to finding the happy medium, because it's difficult to evaluate a patient to an extensive degree. I would say especially a senior, because they need help with that telemedicine visit. There needs to be a staff member from the facility. Hopefully that staff member knows and can help to answer questions, but it's difficult to get information directly from the patient. So if I'm not on site, being able to talk to multiple team members, which is a frequent course when I make my visits, just having a telemedicine visit is limited. So we're now having to pivot back to how do we do most of our visits through face-to-face, but some visits through telemedicine.
Many seniors want to age successfully at home. Do you have recommendations on how seniors can improve the likelihood of aging successfully at home?
Part of my focus is being an assisted living advocate. I see the benefit of being in a group setting and the benefit of activity and movement and having someone to look after your healthcare needs. So it kind of depends on what you consider home. Home to me could be a lot of different places. I assume you're meaning a private home. And I would say that if that home environment can provide the nurturing needs of a senior to the extent an assisted living can, then yes, that home environment can be a positive experience. Is there interaction? Is family coming in and being with them? Are they maybe getting out? Are they going for walks frequently? Are their nutritional needs met to a sufficient level? And so, as far as being at home, that would be my focus of family members. How can I successfully keep mom at home? I would say focus on those items, and then it can be a successful aging process.
So social engagement, physical activity, nutrition.
Correct, 100%. Those are, I would say, some of the 3 key pillars, other than just making sure that their medical needs are being met.
How does medical care for a dementia patient differ from that of a cognitively healthy senior?
Sure. So, one could liken it to pediatrics in that it's very difficult to get a history, to get information from a patient. So there's a lot of history taken from multiple sources. Sometimes I feel like Magnum PI or pick your favorite television, personality, private investigator, in that I need to talk to the nurse at the assisted living. I need to talk to one, maybe 2 different family members. Maybe the patient was recently in the hospital. I need to call them. So it can be challenging to try and figure out the current situation. And then a lot of times, I'm seeing a patient for the first time and I'm trying to piece together, well, what was their past history. Family members sometimes will say, hey, I'm in New York or I'm in Los Angeles and mom was in New York and she's just now moving here and I'm overseeing her care and I have no idea what happened for the last 30 years. So it's hard to piece all of that together. They're try and tease things out of the patient, but it certainly can be challenging.
According to the CDC, 85% of older adults have at least one chronic health condition, and 60% have at least 2. Are there common comorbidities or chronic health conditions that are frequently seen with dementia patients?
The first thing I think about as far as a comorbidity in seniors is the psychological components that go along with dementia, and that includes behaviors like agitation, depression, suicidality, and then related to that are Flo's medical conditions like not wanting to eat, frequent falls, and so that's primarily what I think about. But the other medical issues frequently, there's congestive heart failure, there's diabetes, there's chronic kidney disease. My focus very much is what I would say palliative care. So I'm focused on a patient's comfort. And whereas, a younger patient, let's say 65, they're going to go to multiple specialists and they're going to get frequent tests and labs and ancillaries. My focus very much is comfort. So I'm not going to be sending someone to a nephrologist necessarily for chronic kidney disease. I can handle most levels of chronic kidney disease. And so that at the end of the day, there are multiple chronic conditions, but I have to handle all of them. But really, comfort is the biggest focus.
Thank you for bringing up palliative care. Palliative care is described as improving the overall wellness of patients with serious illnesses. I'd love for you to talk more about what palliative care really is from your point of view, and at what point in a patient's life should the family start thinking about transitioning someone to a palliative care program?
It's a good question and a frequent question that I get asked, and it's there is a spectrum as far as if you think about someone who's on hospice, they need to have a life-threatening diagnosis and they need to have a life expectancy of 6 months or less. So let's say someone has dementia, not necessarily everyone with dementia is dying in the next 6 months. So the two need to go hand in hand. They're either maybe now they're bedbound, they're not eating, they're not talking. So that's potentially someone who's going to be on hospice. When you reflect back to what is in someone who could be on palliative care, well, that dementia patient who's maybe not dying in the next 6 months needs a lot of focus on their comfort, needs a lot of focus on if they're in pain, helping to support their nutrition as much as possible, their anxiety. And what I'm doing on a day-to-day basis, really for all my patients, is palliative care, because what the general concept of palliative care is bringing more resources to help the patient, and in particular bringing more resources into their home. So as a physician, I'm going into their home, I'm bringing in labs and ancillaries, a nurse practitioner following up, coordinating with home health to bring in additional nurses. So at the end of the day, it's a more focused care and trying to prevent the patient from having to go out to a physician's office, and really a focus on keeping the patient out of the hospital, because that cycle of going to the hospital, coming out, every time they lose a little, like you might deal with the urgent issue, but if maybe that urine infection that they went to the hospital with could have been dealt with previously at home more successfully, and oh, by the way, they were exposed to other things, and oh, by the way, they returned from the hospital with a pressure ulcer. So very much palliative care is focused care on their comfort at home.
Psychotropic medications have been used historically for managing behavioral and psychological symptoms of dementia. How do you think of psychotropics in terms of balancing sort of the needs to keep mom or dad safe from their symptoms versus those psychotropics really causing risk in and of themselves?
It is interesting sometimes that I have patients where the family says, oh, these are just, it's kind of the dementia will unmask behaviors from maybe when they were, younger, and like mom was, kind of always difficult and challenging, but sometimes there are new behaviors that come about, which is in particular, I think, quite, disconcerting. And so I try and look at things holistically in terms of, yes, there's a role and a place for medications, and the first step is not medications. The first step ideally is behavioral interventions. And so what can a family member or staff member do to interact with the patient to try and help to soothe them and allay some of these behaviors? Be it, is it playing music? Is it physical touch in some therapeutic ways? Maybe there's certain foods that that can help to allay their anxieties. But it's an unfortunate reality that in many times with dementia, there are behaviors that can't be controlled from those interventions alone, and medications are necessary. And it's a difficult discussion because the families are leery about addictive potential. They're leery about side effects. The addiction piece is, to me, for an elderly patient with dementia, it's something to think about, but they need the medications, and there's a clear therapeutic benefit. But the side effects certainly are real, as far as antipsychotics and benzodiazepines causing falls and potentially dizziness and potentially higher rate of cardiovascular events. So, in particular with psychotropic medications, it's important to have that discussion so that the family is aware. So there is a time and a place, and I think the best is kind of melding both. So can you limit the behavioral medications and using other interventions? And I would just lastly on that point, I would say as a physician to try and rule out any medical conditions that might be causing change in behavior. So because those do happen as far as maybe thyroid conditions, frequently infections, in particular urinary tract infections are common in the elderly, and they can cause significant behaviors which are not this, it's different than the behaviors in specifically from the dementia.
For many seniors with dementia, companionship of a live animal can help relieve some behavioral and psychological symptoms of dementia. How do you think a product like Tombot's Jenny might be useful for those people where a live animal companion is not a viable option?
I have a dog, a Labradoodle at home. His name is Lucky, and he's very popular around the neighborhood. And I will bring him sometime. I have a couple of patients in not far from where I live, and I'll bring him sometimes. And the positive interaction, the benefit is remarkable. So I see I've seen the changes firsthand, and clearly taking care of a live pet can be challenging for patient and or family. And so to have something else, have something similar that to provide the same level of stimulation and frankly to provide the same level of what I was referred to before, like the non-pharmacologic interventions to help with behaviors. I just think it's a great alternative. Provides that stimulation, that interaction, and activity. And I've seen patients in facilities who they might have a doll that they hold and they interact with the doll, but these are not dolls and these are babies, like baby dolls, and so they're inert. And to have something like Jenny that's alive, follows their emotions and is more interactive to me is a real game changer.
COVID has sponsored an outgrowth in telehealth, but it's also created a huge demand for technologies like remote patient monitoring, where the types of diagnostic tools that you might have with you are not necessarily with the patient where that patient resides. What kinds of technologies have you seen generally, and has COVID brought anything else to the fore in your practice?
So telemedicine certainly is one, and there's been a huge growth in telemedicine. And I would say from a general, in the healthcare financial perspective, there's a lot of money flowing into healthcare, and some of that is into actual patient care, but a lot of it is into healthcare technology. I would say as a physician, sometimes it's eye-popping to see the numbers that electronic health record company or remote patient monitoring company is being sold for. But from my perspective, it's exciting that there are more companies out there to interact with. And my particular niche is in senior care. And there have been a number of technologies that have reached out to me similar to Tombot. How can we get your feedback on this product? How can we get this product into seniors' hands? So some of the things that I've seen, you mentioned remote patient monitoring. There's a lot of focus on how can we provide, similar to telemedicine, how can clinical care be provided without without a physician actually on site. So we do utilize remote patient monitoring to a significant degree, not just for my patients, but I help to consult with companies who are providing remote patient monitoring, and for even not for my own patients. It allows for checking of vital signs remotely, and a physician sitting in his office, seeing those vital signs and getting alerts. And it's a very helpful adjunct to help keep patients out of the hospital. Other technologies I've seen, I've been involved with a technology that provides, it's a virtual reality gait system for seniors. So they're walking on a treadmill, they see a screen in front of them, and what they see on the screen in front of them is a street, and they need to navigate certain aspects of the street, and the sensor sees how their feet are walking, and they can go, they can go over the stone, they can go around it, and it's like gamification of walking. And that's from a company called Gait Better. I've seen artificial intelligence brought into the senior space, and how can we help physicians and physician teams to make better decisions, identify patients who are maybe in this frail state, who are at risk of going to the hospital. How can we engage caregivers to have the language to speak to their patients, to get them involved in their care. That was a company called Wellbeat. And so it's exciting that all these technologies are out there, and as a physician, particularly one who takes care of seniors, it's been a little bit of a transition, but it's an interesting transition to work with them and see how they can fit into the senior space.
Thank you, Dr. Lefferman. My guest today has been Dr. Matthew Lefferman. On behalf of the entire Tombot team, thank you for watching. For more information and to learn how you can bring puppies to those desperately in need, please visit our website at www.tombot.com. I'm Tom Stevens. Be well.